Okay, morning everybody. Nice to see some familiar faces. So I'm Tom Symes. I'm one of the orthopaedic surgeons here in Hull, and I mainly do hip and knee replacements and hip revision. So I'm going to be talking about two-stage revision for infected hip replacement. So we've heard about this before. Basically, infected joint replacement is a very costly thing. Slightly different figures from JA's figures. This is taken from NJR and from the mandatory standard surveillance survey that's carried out every year. About 0.5% of hips get infected. Slightly lower than cabbages and large bowel surgery, but you'd imagine that it's cleaner surgery generally. But it's a very costly thing for the patient and for healthcare in general. So different options. We've heard about DARE. For the first 4 to 6 weeks, you can try and suppress the infection with antibiotics. 1 stage, 2 stage. You can do a girdle stones in select cases, and you can do a partial exchange. That's where you leave some of the implant in place and remove the other part. So again, we've heard about the history. The management of infected joint replacement. Won't go over these again, but you need to know this for the exam, the sequence that you go through. I'm going to talk a bit about the surgical technique and then some of the evidence afterwards. So we heard from Jay about the definition. Again, something that you should know for the exam. There's UK and American definitions, but yeah, probably know one of those. So what's the principles of two-stage revision? So it is considered the gold standard. It's what's been done sort of traditionally. But the patient has to be able to withstand 2 big operations, and they are both big operations. I always tell patients it's bigger than their original operation, longer hospital stay, higher risk of complications, and they've got to come back and do it all again after another 6 weeks or 12 weeks. The principles, you really need to take all of the infected material out, the necrotic tissue, take out all the implants, cables, cement. You're generally left with a bigger wound, so close the dead space and possibly put in drains. Then antibiotics, we'll talk about the duration of those, and then the second stage, probably at least 6 weeks later. So a bit about surgical technique. This isn't minimally invasive surgery. It's a wide exposure. You want to excise all the infected tissue, excise any sinus that there is. Most hip surgeons, I think, doing revisions do posterior approach. You probably can do it through other approaches, but you generally get a more extensile approach. Try and identify tissue planes because this is revision surgery. The tissue planes aren't what you get with primary surgery. So it's useful to try and identify them on the way in for repair afterwards. Really helps to try and identify the sciatic nerve. I try and do that in all my primaries and revisions. Not always easy, and I think, to be perfectly honest, sometimes if you spend ages trying to find it and you can't, then you can't always do that 100% of the time, but it really does help if you can because it gives you a lot of confidence identifying your acetabulum, doing your soft tissue repair afterwards. Something I always teach my trainees is that the gluteus maximus insertion into the femur really can guide you because it always tends to sit underneath, the nerve always sits underneath that. The G-max insertion is a really good landmark. It can bleed when you divide it, so you need to divide it away from the bone, but it really does guide you to where the nerve is. And you need to do big soft tissue releases to get good exposure. So you need to learn this from somebody who's does these regularly. The G-max release, anterior capsule release, all your external rotators. And often with exposure to the hip particularly, I'm sure it's the same with the knee, it's a process that takes time, and even in each operation, the exposure gets better over a period of 15-20 minutes. You can't just make a few cuts and you see everything. You need to sort of stepwise approach, and generally it'll come. Sometimes it gets easier once you've taken some of the implants out, and you can see a bit more. But I suppose when you're starting to do these, you don't want to panic that you can't see everything straight away. Just follow the steps that you've been taught, and then generally you'll get a good exposure. Sometimes you need to do more release, sometimes less release, but there's a sequence that you follow. We've talked about the microspecimens, so yeah, five or six specimens. Now, there's debate about whether you take the antibiotics, or you give the antibiotics before you take the specimens. I think there's actually a couple of trials that show it doesn't make a difference. Generally, we wait until we've taken the specimen before we give the antibiotics. So, but yeah, you know, it depends maybe where you're working, but I'm not sure that it makes too much difference. So just a couple of slides on the exposure. So this is posterior approach. So this is, you know, where you want to divide near the bone, the external rotators, and on that slide, the second slide, you can see the Gmax coming around and inserting into the back of the femur. That's exactly where the nerve is. So if you follow that down, you'll find it, because often the back of the hip, if someone's been in that way before, is covered in scar tissue, and it's very difficult to actually pick out the sciatic nerve easily. So it's easier to extend your incision and go to some virgin tissue. So taking out your implants, you can need quite a lot of kit to do this. So if they're uncemented implants, thing that's made this a lot easier is the explant. Most of you have seen that. So device that cuts around the uncemented implant. What can make that more difficult is if you've got screws in. Now, if you've got screws and you've got a poly liner, that's easy. You just put a drill and a screw and it'll pop out. If someone's used a dual mobility bearing or a ceramic liner, it can be more difficult. There are specific instruments to try and get them out. Occasionally, you just can't get them out and you have to crack the ceramic or divide the ceramic somehow and get it out. So most of the time, it's worthwhile spending some time trying to get the metal liner of a dual mobility or a ceramic liner out, because it makes the next bit so much easier. Femur. So uncemented femoral implants, if they're loose and with infection, they can come out very easily, but they're not always loose, and they can be a real pig to get out. So lots of different techniques described. Flexible osteotomes to get down either side. A little burr to create some space, K-wires. There's an uncemented Oscar, so people use Oscar for getting cement out, but there's an uncemented version. Finding the stem extractor that fits your femoral component is quite useful. If you can screw it in and knock it back, but you know, that really does help, rather than using the one that just fits around the neck. But if all else fails, an ETO is a really good technique to learn to do safely, because it can actually be a lot quicker than and less destructive than trying all those other things. So if you don't think you're going to get your stem out, you know, safely, then doing an ETO safely is probably better. Cemented, uncemented and cemented implants, some are easy, some are difficult to take out. So again, when you're taking the acetabulum out, usually you can get around it with osteotomes. You can remount the poly if you want to, particularly if you're doing a not infected case and you want to preserve the cement mantle. You can break up the cement with osteotomes or a drill. If the cement's gone into the pelvis, that's a different matter. Now, if you feel like you have to take it out, then often you want somebody with vascular experience to be around in case there's a problem. You don't always have to take it out. If you think it's going to cause more, you know, likely to cause more of a complication than it's worth, then you might be better leaving it in. On the femoral side, if it's a polished taper stem like an Exeter or a CPT C-stem, they're very easy to knock out, but then you've got to get the cement out. So getting the cement out, again, different techniques, using osteotomes, Oscar, or to be honest, what I go for mainly, if there's well-fixed cement, I generally go straight for an ETO, because it's very difficult to get well-fixed cement out safely without causing more damage to the bone. So once you've got all your foreign material out and your infection out, then you want to irrigate the wound. So we've heard about using pulse lavage. There is a bit more evidence that dilute betadine or chlorhex reduces your chance of infection. There's some products made by the implant companies now. Zimmer makes something called Bactisure, which has got some lab evidence that disrupts biofilm. I'm not sure it's been proven in practice yet, but there's some lab evidence. We used to use lots of hydrogen peroxide. That's not really allowed by MHRA anymore. And there's also some moves to put antibiotic powder in the wounds. We'll talk about that in a minute. Then you want to close your wound. So you want to try and close dead space by closing it in layers. You can use a drain if you think there's a lot of discharge. Some surgeons favour drains, some not. I don't tend to use drains normally. Tranexamic acid is a great drug. I use it as much as possible, and I think really does reduce bleeding, both in primary and revision setting. And then suturing, I quite like the new barb sutures because I think they do provide a really nice watertight seal. The skin closure, I think, depends on your wound. If it's a very infected, inflamed wound, it's not gonna tolerate a continuous subcuticular suture. So I tend to use interrupted heavy nylon. So that you've got to judge at the time. Dressings wise, if it's a primary hip, I tend to use skin glue and Aquacel, but for these cases more and more I'm using a suture line vac, so closing the wound with whatever suture you want, some Epitel, foam and a vac dressing. I think it's nicer for the patient, nicer for the nurses. There is evidence that it reduces infection in some of these cases as well, and you know these wounds are going to leak. If you've had a leaky wound before the operation, it's very likely to leak afterwards. You could be accused of trying to hide infection, but you put it on for a week, try and suck out all of the serous fluid that's coming out, and then you can inspect the wound and see how it looks and look at your markers. But I would encourage you to use those. They're very useful. So I've missed a little bit in between, but I wanted to leave this because this is probably the main bit of my talk. So what do we do with the joint? So traditionally we've done girdle stones, which is kind of easy. You just take everything out, you wash it, try and close the capsule and you leave it, and then you go and have a cup of tea. But it's pretty terrible for the patient. Some of these patients get a huge amount of leg shortening. This isn't talking about hip, obviously, here. Find it really difficult to mobilize. They've got to wait another 6 weeks. But more importantly, all the soft tissues shorten, and it can make your secondary reconstruction really difficult. People used to put impregnated beads into hips. I just saw a patient in the clinic yesterday, had some beads put in last year. All the wires broken, the beads have gone everywhere. Personally, I don't particularly like beads. And then there's articulating spacers, so the off-the-shelf spacers like Spacer G, and articulating spacers. So I'll talk to you a bit more about those in a minute. So you've got to decide what you're going to put back in the joint. So top left is Spacer G, so they come in different shapes and sizes. They tend to come in a few different head sizes, maybe 3 different head sizes and a couple of different lengths, which is better than a girdle stones, but still the head size doesn't always fit the acetabulum. The offset, as you can see, doesn't vary very much and is usually a bit less than the patient's. So the Prosthetic is a device that DePuy market. So basically it's a stem that you put in a clamp, and before you put the stem in the clamp, you surround it by cement, clamp it all together, and it produces you a hip replacement stem that's covered in cement. I don't know how much they cost, but that's what you do. It all looks quite nice. I've never really used it, but what I generally do is actually top right, which is Kumar's technique, which is actually a lot simpler. So I'll describe that in a minute. So 2 patients that changed our practice. So this is, again, what I sort of wanted to major on in the talk, really. So this was during COVID. This lady I knew quite well because she'd broken her other hip previously, and we'd replaced that. She's quite young. She's independently mobile. She'd had a really bad surgical history. She'd had lots of bowel surgery and did have a GI fistula, but was remarkably independent and was working still. But she presented with this left hip infection. She was really, really poorly, actually, and she needed surgery on that hip to treat her infection. And I put a Spacer G in, debrided it, and put this in. But first post-op X-ray, you can already see it's subluxing, and fairly quickly over a period of 2 or 3 weeks, it dislocated. And I think the trouble with this is that you're in a really difficult situation at this stage because you've only just done the operation, patient's possibly still quite sick. You don't really want to take them back to theatre because it's too early to re-implant something, really. We want to wait 6 weeks ideally. But the patient might be in quite a lot of pain. She couldn't sit up because the femoral head was basically anterior and it was sort of stopping her sitting. So, really, really tricky situation. And this was a young lady. We'd hoped we might be able to reconstruct her hip at some stage. Anyway, she was still too sick, and we just had to take it out, unfortunately. That might have been what she needed in the first place, to be honest. But it really didn't feel great. Second patient, Mr. Muir might recognise this patient. So this is 2017 when Mr. Muir was one of the registrars. So he was a particularly unkempt 54-year-old. He did a very good job of the gamma nailing, so I'm not going to embarrass him. But he turned up just before COVID with that X-ray, and came with his dad. He didn't really speak very much. The patient, he was sort of, I think he had quite significant mental health problems. Anyway, he'd been struggling with his hip for maybe a year or so with that, which looks pretty awful, isn't it? So we discussed our MDT. We couldn't convince ourselves there wasn't any infection, and we decided to go for a two-stage revision, which may have been the wrong decision. Anyway, so we put a spacer G in to try and give him some length, and it quickly dislocated, and he actually developed a sciatic nerve palsy because of that. So it just didn't feel the right way to manage these patients. So this happened at COVID, and we were all sat at home not doing very much for a couple of months. Looked at quite a lot of Twitter at the time. And I don't know whether many people realise that basically the extra hip unit were putting out a tweet, I think almost every day for about 200 days, which was great. And they basically just summarised their book, which is a great book actually, and you can see how well thumbed my version is. So I thoroughly recommend that. Obviously it talks mainly about cemented hips, but it's got a lot of really good stuff, particularly about infection. It's great. So what they do is something called the Kumar's technique, and it's really not that difficult. You do your debridement, and then you basically put in a badly cemented hip replacement. But there's a few different sort of aspects to it that are important. You want to try and get a big head size to reduce the risk of dislocation. So you can either use a normal poly cup with a big head size, but if you've got a small patient, you can't get a 36 head. So you can just use a liner from an uncemented shell. So you don't have the shell, you just have the liner. The back of the liner is smooth, so you get a burr and scratch the back of it with the burr, make it into a cemented cup. It's a thin poly, but it doesn't matter because it doesn't have to last that long, and then you cement it in place. You don't pressurize the cement, so you put the blob of cement in the cup and use in the socket, and then use the socket to pressurize the cement. So it doesn't really go into the trabeculae of the socket. The advantages are that it restores offset and leg length as much as you want to. It allows a staged reconstruction, so you can, quite often these patients have shortening, so you can lengthen them a little bit, and then when you come to the second stage, you can lengthen them again. You can put lots of antibiotics into the powder. So now we have powder with Gent and Vanc, Gent and clindamycin, all sorts, but you can add loads of antibiotics. And in Exeter, they put up to 4 grams of antibiotics in their cement. So now that sounds a bit crazy, but again, it doesn't have to last that long, this cement. It's only meant to be a temporary thing. But also you can tailor your antibiotics to the infection. So if you know it's Staph aureus, you can put loads of Vanc in. If it's something different, you can put different, and you can tailor them. Now, not all the antibiotics are heat stable, so you have to work out which antibiotics will work. But I'll show you what they are in a minute. The patient can actually weight bear on this. It makes your second stage so much easier because basically you've made all the soft tissues the correct tension. Also, because the cement in the socket is blocking the formation of any membrane and pulvinar, you take it out and you've got a fairly fresh acetabulum. They dislocate much less commonly. And they're loads cheaper. So if you use a normal implant, this is just got this from our implant reps yesterday. So the costs of a normal CPT stem, a liner from a primary hip, and a metal head is £480. The cheapest spacer G is £1,750. So it's vastly cheaper than, and I think loads better, to be honest. Takes a bit more work. These are the antibiotics that you can put in it. So you can put more Gent, more Vanc, clindamycin. Only certain cephalosporins will go in there, but these are the things you can put in. This is how you do it. So top left is how you make the femur. Probably the main things are to just let your cement go off more than you would do normally, because the worst part is actually trying to get them out again afterwards. The acetabulum tends to come out fairly easily. The femur can be a real pig to get out the cement again. It's like taking all your cement out the first time round. So particularly on the femoral side, resist the temptation to put it in too early. So yeah, it's a fairly straightforward technique. This is one after my epiphany. So this lady was about 3 months after primary hip replacement. Again, it was kind of COVID time. She was missed by her GP and presented with an obviously really infected, really inflamed. There was some discharge. She was a little bit septic. So we took it out and did a Kumars. You see how big the femoral head is compared to the socket. You'd never get that in normally, but it's just because it's got a thin polyliner. So July 21, she actually waited 2 years for the revision. And, you know, she was actually fine. She wasn't even that symptomatic really at the time of revision. She was getting a little bit of clicking. The acetabulum was loosening a little bit. So you change the stem and cement it properly. Change the cables. So interval between the two. There's a bit of evidence in a minute on that. Most of us go for a minimum of 6 weeks, but you want to be fairly sure the infection is eradicated. Some people do a repeat aspiration, but most of the time it's just clinically on how the patient appears. Wait for the CRP, not always to come down to normal, maybe less than 50. You want the patient to be off antibiotics for a couple of weeks and then do their bloods, but we normally go for about six weeks if we can. But with the Kumars technique, it can be a lot longer. And then when you reconstruct it, you can do what you want, what you feel is suitable for the patient. Much easier if you've had the articulating spacer. Take specimens, but in terms of antibiotics, we tend to treat the patient as if they've had a primary with induction-only antibiotics most of the time. So, 1 or 2 stages. Jay talked previously about the MDT approach. I think the reality is that all these patients get discussed at an MDT, and we make the decision in a team approach with surgeons, microbiologists, and radiologists. What the British Hip Society says is that single stage might be appropriate when you know what the bug is, when you've got an antibiotic that can treat it, and when the soft tissues are okay. But 2 stages, probably better when you've got multi-drug resistance, multiple previous surgeries, and fungal and atypical infections. These are the results. This is a bit historical, but historically the results with 2-stage are better. But these studies are kind of in the sort of 90s and 2000s, most of them. This is the international consensus meeting. So they're saying, what would be indications for 1 stage? There's quite a few conditions where 1 stage isn't a good option. So I suppose I'm meant to be pushing 2-stage here, but so that there's 2 stages is the gold standard, and I suppose what we want is 1 stage to be maybe suitable in certain occasions. So this is probably the only RCT. I won't talk about this a lot because I think Jay is going to talk about it, but there is one RCT that shows not much difference. But it's only one proper study, really. All the other studies are these are systematic reviews of the other studies, and they're cohort studies, comparative studies. So there isn't great evidence to guide you from the literature. So spacers, there's pretty good evidence, as it says here. The level of evidence is strong that the indications for articulation spacers are better. What it talks about here is when you should use non-articulating, and that talks about major bone loss, ligamenting, lack of abductor mechanism, and soft tissue defects. I would argue that you can still use them in bone loss and abductor mechanisms if you're careful. So this chap is one of the IV drug users that we looked after from south of the river. So 2019, he attended with septic arthritis. He declined surgery. So ended up with a hip that looked like that. Then he got clean, he said, and wanted something doing about his hip. So that's what we started with top left. I'm not sure you can see that. Basically, kind of made an augment out of cement and brought his hip center down about half the way it should be, which then meant when we did the second reconstruction, he could then restore his leg length and offset. So you can deal with some bone loss with the technique I've described. This is one we did this week. Again, this chap's quite interesting because he's already had an infection in his contralateral knee, which is at a first stage for. So we did a first stage of his hip on Tuesday. So yeah, and he's got quite, again, big defects superiorly, and it just, stages that reconstruction to the next stage. Spaces versus beads. So there is a study looking at spaces versus beads, and no surprise, the spaces, generally do better, basically. Higher hip score, short hospital stay, better mobility, and lower rate of dislocation. Couple more things in the evidence. So, no surprising, antibiotics should be added to the cement. Vancomycin for a lot of patients. Drains do not reduce effectiveness, so drains are okay to use. They felt. They didn't feel that you could really guide on when we should do this, the second stage. 6 weeks is about the average. Some studies seem to show worse results when you delay it. Some seems to show better results when you delay it longer, so you can't really be guided. So one of the things we always come across is whether we can leave cement. We know we can leave cement if we're doing an aseptic revision. We're doing cement in cement revisions, they're very successful. Can you leave it with infection? So there is one study that shows good results. Now this sounds a bit crazy, but what they say is that if you can't get your knife in between the cement and the bone, then the bugs can't get down there either. Yeah, I don't know. But anyway, sometimes, you really don't want to take the cement out if you've got a really poorly patient. So, you won't be sued if you do leave it. So this is a bit about irrigation. So there seems to be more and more evidence coming out that diluted iodine can reduce your rate of infection. There's only one RCT I could find, which is it was in revision patients, reduced the infection rate, and there's a few cohort studies in primaries that seem to show it. The vancomycin powder thing, again, I couldn't find quite as much evidence for that, and certainly one of them seemed to show more wound complications using it. But that might be something that will come out in the future. So the summary is that I think 2 stage is still the gold standard, and a single stage is something that we do in only selected situations, particularly using 2 stage for those indications there. The Kumar stage, we quite a lot of us call that 1.5 stage surgery, because it's giving a patient a hip that they could probably live with for quite a long time, to be honest, and same for the knee. And really, in reality, we always discuss these cases and make a decision based on several different factors as to what we should do. Thank you very much.
Thank you very much, everyone. Hopefully you've all grabbed a cup of tea or coffee and some bits of cake. So Tom's very nicely talked about 2-stage revision. And really, we're not going to come to fisticuffs, because in all of this, you treat the patient on a case-by-case basis. But let me talk to you about single-stage revision, okay? And there'll be a little bit of overlap. So basically, Buchholz, he was the professor of orthopedic surgery in the 70s and 80s. He set up the Endo Clinic in Hamburg, which if you get an opportunity to go to, is well worth a visit. And they have really led the way in terms of single-stage revision, and pretty much almost all their practice is single-stage. And they are perhaps one extreme of a spectrum. But they talked very much about the management of deep infection. They talked about the use of antibiotic spacers, and and Professor Buchholz was very much a pioneer in the use of these techniques for treating these deep-seated infections. If we look at the only trial on single-stage versus 2-stage revision of any note in large studies, Tom's already alluded to the INFORM trial out of Bristol with Ashley Blom and Mike Whitehouse group, multi-center trial. 3 units was from Sweden, 12 in the UK, 140 patients, randomized to single or 2-stage, 65 in the single stage, 75 in the 2-stage. This is for hip replacements, not knee replacement, hip replacements. There really was no clinical difference in terms of outcomes at 18 months. The only caveat to that was that patients qualitatively preferred single stage in terms of function, the need to avoid second operation, etc. And at 3 months, it was cost effective and they had better function. But otherwise, no difference. Faraz Haddad's group wrote a review article a few years ago in the BJJ, again looking at the role of single stage for chronic infections. Again, UCH is a big proponent of single stage. But again, they did a systematic review, 22 studies. Most studies aren't great. They're pretty poor, only 5 prospective. A lot of this is case retrospective studies, almost 1,000 patients. Recurrence rate from a single stage varies enormously. The very highest centers, 0% to 18% at 2 years. But again, really, they had clear indications of when they would do a single stage. So you pick your horses for courses. So they said that you need to identify the organism preoperatively, so no surprises in the middle of the operation. The organism had to be sensitive to antibiotics and again, not multi-drug resistant, and host factors such as good soft tissue envelope. No point doing a fancy bit of kit and the soft tissues fail. It's a disaster. This was a review article from Craig Delaval and Brian Springer in the US, so single versus 2-stage revisions in PJI. Again, eradication rates for single stage, pretty good, 82 to 100% at 5 years plus if you look at all those studies. But you look at the number of subjects, there's small numbers, okay? Only a couple of large centers, but they're all pretty small, and this was a mix of hip and knees. And then finally, this was a BMC musculoskeletal disorders review article from China, 40 studies, almost 9,000 patients. No significant difference in postoperative reinfection or reoperation rates between 1 or 2 stage, i.e., we need to do more trials. I think in practice, the INFORM trial tried to do it with hips. I think they're planning a knee one, but essentially it's a very hard trial. Hats off to them for even attempting it because there's such variation in practice and patients. So I'll tell you a bit about my practice, okay? For me, the indications depend on certain things, the host. For some very elderly, frail patients who may not tolerate 2 operations, elderly patients with multiple comorbidities may not survive, being blunt, long enough to come back for their second stage sometimes. On the other hand, they also have to survive prolonged surgery during your single stage. So it's a bit of a balance between risk and benefit. The host has to have good soft tissue envelope. That is critical. And therefore, having your plastics colleagues, and I work very closely, and in the fracture-related infection world, we work very closely with our plastic surgeons because without them, we're doomed to fail. And for example, in the knee, you need to really have an extensor mechanism and ligaments. The microbiology is the other bit. You need a single organism with appropriate sensitivities that you have good antibiotic therapy treatment. No point trying to do this if it's an organism that is multi-drug resistant and you're going to struggle to have antibiotics. I talked in the past about the similarity between alarm. Saved by the bell. So I talked before about the similarities and overlap between cancer therapy and fracture and infections. In a way, antibiotics are your chemotherapy, and what we do is the mechanical debridement of that infection, and they go hand in hand. So for me, not polymicrobial PJI, not multi-resistant organisms, and not atypicals or fungal. There's an issue about whether if there's a sinus, does that constitute an issue with the soft tissue envelope, and you can argue the toss. If you do a radical debridement, plus you have to remove the sinus tract, and you can get good soft tissue closure, well then you potentially could do a single stage revision. So again, that's a case by case. So how do I do a single stage revision? Really, all of this is semantics. If you think about it, a single stage revision or 2-stage revision is part of a spectrum. When we do a single stage revision, the first bit is the actual eradication of the infection mechanically, the debridement. Whether you then wait 6 weeks or 60 minutes to do your second stage is part of a spectrum. But the principles still remain the same. There's no point dealing with the reconstruction, no matter what the time delay in between is, if you do not get the first bit right. So the first bit in my case is I don't worry at all about the reconstruction. It is all about eradication of the infection. Debride more, debride more, debride more. In knees, I do not use tourniquets at all, ever, because I find that I want to see the bleeding, soft tissues, etc. You take your soft tissue specimens. I soak in betadine, but Back to Shore, which is made by one of the companies, is another product, which has acetic acid and things like that as part of a cocktail. And the other thing about any revision surgery, whether it's hip or knees, you need to be able to remove the implant safely without causing catastrophic bone loss. So in all of this, like any orthopedic surgical principle, you need to know what you're doing. Your implant, so you can plan accordingly. You need to sometimes get special kit. You need to plan whether or not you need to do an osteotomy. If in the hip, ETO. In the knee, do you need to do a tibial tubercle osteotomy to safely remove that implant and cement, and therefore order the appropriate kit to do that. You then basically, that bit all gets, you've done your first part, you then re-prep, re-drape, clean instruments, everything is clean. At this point, you can then give your prophylactic antibiotics. At this point, you are now saying, I've cleared the infection. This is now like a routine reconstruction. So this is an example, it's not in my theatre, but I found that this was essentially, you can see here, that's all the dirty stuff put away to one side. They've even closed the knee, re-prepped, re-draped, and completely clean sets of instruments, okay? So everything dirty gets moved out of the way. And that is why it takes longer, because all of this may take several hours by the time you do all of this, do your first part reconstruction. So the patient has to be physiologically able to withstand that prolonged operation. So I'm going to talk about 1.5 stage revision, okay, that Tom has also talked about. So the role of implants as articulating spaces has gained more and more interest, whether it's in the hip, which we call the Kiwi, based on the New Zealand fellow, and in the knee, we've called it a knee-wee, okay? And in Leeds, we use a knee replacement with an all-polyethylene tibial component as an articulating spacer. And there's a fair amount of studies now that show that for some patients, they do not proceed to their second stage. This articulating spacer is good enough for them. So in Nottingham, where I did my fellowship, almost about 30% did not need to proceed with their second stage, and that's what we found in our own data in Leeds also. So these are some of the papers that have looked at this role of this articulating spacer using primary implants as your stage 1.5 or 2 sort of procedure. And all of them shown that for many patients, that is good enough for them. So I come back to that elderly, comorbid, frail patients. This might be your compromise, that actually you take everything out and you put in, say in the knee, a temporary articulating spacer, which actually in that patient ends up being their definitive implant. If you had to go back in, where you can go back in a year, 2 years, I've got patients who have done this and they're still going strong 5 years down the line. So and they're happy, they don't want further surgery. What are the contraindications? Massive bone loss, otherwise the implant you put in is going to be unstable, loss of extensor mechanism in the knee, collateral ligament insufficiency around the knee, or if they've had multiple articulating spaces. So this is an example of a knee replacement with an all-poly tibial component. The other thing I am a big fan of is these dissolvable antibiotic pellets, okay? I don't use beads for the same reason Tom has alluded to as well. These things dissolve, but they elute out antibiotics for 4 weeks plus in high concentrations. The reason I use it is because I like to have a whole load of antibiotics up and down after I've really cleaned out that canal, and it can't go anywhere, so it doesn't leak out of the soft tissues. And I found in my practice that by using this, touch wood, it seems to work pretty well. And I use this technique for when I'm doing large megaprosthesis because the infection rates then are significantly higher, up to 20% or more. And you can put whatever antibiotics you need, or indeed antifungals, into this delivery system. So in summary, single stage revision, absolutely fine for the right patient if indicated and appropriate. But the 1.5 stage is a compromise option that can work very well for some patients. We've already said the key in all of this is the MDT. Everything now gets discussed through the MDT. For the exam, you will say MDT, like you were discussing a sarcoma or anything like that. And it is case by case. One size does not fit all. So you need to know your patient, you need to know your implant, and you need to discuss it all via the MDT.